Next speaker is going to be Dr. Max Hamburger. Max received his undergraduate at Rutgers, his medical degree, and his post-medical degree training at NYU. He was then at the NIH. Max is the managing partner of Rheumatology Associates of Long Island, which is the largest group in New York and one of the largest groups of rheumatologists in the United States. He's assistant professor of medicine at State University of New York at Stony Brook, and he's going to talk today about implementing outcome goals in treatment of rheumatoid arthritis. Max.
David, thank you very much, and thank you all for joining with me today. The presentation that I'm going to give you is a CME talk. Many of you have seen the proliferation of treat-to-target talks. I think virtually every biologics company at this point in time has seized onto the idea of treat-to-target. And about a year or so ago, a number of us felt that there was a need for an unbranded talk. So we put together a committee of about 25 physicians. Many of us are in the trenches, like most of the audience here. But we were fortunate enough to have 4 of the members of the International Task Force on Treat to Target. So Joseph Smolin and Dan Alitaha came to work with us from Vienna. Alan Gabowski and Ed Keystone, who are also on the International Task Force, were part of this group. And we spent a weekend reviewing all of the data that have been reviewed by the International Task Force that we'll come to try and cull out, again, in an unbranded way, an approach to looking at this. So our title is a little cumbersome up top, but this is a treat-to-target presentation. So there are some CME information slides that are in your binder that I'm not going to read through now, but please take a look at them because there are forms in your binder and out at the desk that are important for you to complete if you wish to get CME. So some of the information that's here will seem so obvious that it's kind of like the Bill of Rights, that we hold these truths to be self-evident. So we hold the truth that RA is a chronic and progressive disease to be self-evident. I think by now we've all heard enough about the data, and we know that joint damage is a feature of RA and that joint damage is due to inflammation, and that when damage occurs, it's generally irreversible and damage leads to disability. And I think we also know from many, many publications and sources that damage occurs early with erosion and narrowing apparent in patients who've clinically been diagnosed for less than 6 months. So we again then have a variety of statements about our treatment goals that I think are more or less self-evident and are goals that all of us share. We want to make our patients feel better. We want to improve what they report to us in terms of outcomes. We want to, from our point of view, prevent structural damage, and ultimately, therefore, we want to be able to preserve a patient's function. To that, we want to be able to limit the impact of the comorbidities which are related to chronic inflammation and which are the factors that lead to premature death in this patient group. So we have a target of remission, and I think that if I were to individually ask any of you, we were to ask each other, we obviously have wanted to get our patients into remission. For patients, that means relieving symptoms. For us, it means abrogating inflammation so that we can get to remission as quickly as possible. So this talk is really then going to be, with some backup of the data, a strategy talk. After 14 years of having biologics, I think that the subspecialty has coalesced in the last couple of years about the idea of having strategies for getting to our targets. And I think that this is timely because now we have a number of other diseases where we will start, because of available therapies, to think about treating to target. So we think about treating to target in gout, and you'll hear about that more from Al Morton tomorrow afternoon. Saturday, you'll hear from Michelle Petrie in another presentation that we worked on and we'll have the challenge of, how do we think about treating to target in